We will start from the basics, which will be there. So this is a beautiful heart, and the beautiful coronaries, they are arising from the heart, and what we have to discuss is the different pressures inside it. So this is a very famous diagram which we are learning from the first year of the medical college about the cardiac cycle. So see here, there is the ECG, and there is a P wave. After that, there is a wave in the atrium. So this black line is showing the atrial waves. We all know that there is A, C, and V waves. The red line is showing the ventricular pattern. See, there is a 0 point, and it is touching the 0 point. So ventricle pressures always touch the 0 point. And these are the aortic pressures. They are coming from just like 70 millimeters of mercury here on the scale, and they're going in this way. So we have to recognize the patterns. We will see the hemodynamics step by step in different chambers. This is the ECG. Remember, the ECG is the very, very fundamental tool for measuring the hemodynamics. So these are the pressures which are measured in the LA. We will discuss how we will go in the LA, but these are the pressures from the LA. There is a P wave in the ECG, and after that there is a contraction in LA. So we have an A wave on the LA pressure tracing. Then it is a point where mitral valve closes, then comes the C wave, and at the end of the systole, when the LA is filled, there is a wave that is called V wave. So two descents, X descents and Y descent. So these are the pressures from the ventricle. You are seeing these pressures from the left ventricle, and the green pressures, they are from the right ventricle. So both have the same pattern. They are recorded simultaneously, but we have to differentiate it with the pressure scale. That should be present here. These are the pressures which are taken from the cath lab, and they're from the aorta. And these aortic pressures have a very marked, very phenomenal structure, like that they do not touches the baseline. Here in this picture you are seeing the simultaneous pressures from the aorta as well as from the pulmonary artery. You can see the difference here. The aortic pressures are higher, the pulmonary pressures are lower. So this is a common phenomena that happens whenever we go in LV or RV. You can see here on the ECG tracings, there is a normal rhythm and then comes some PVCs. You always have experience that whenever you go in LV, you find these PVCs. And with these PVCs, you can easily recognize in the pressure tracings that the pressure have effects. Because these premature beats generate lower pressure, and a pause after the PVC, it generates a higher pressure. And this is easily evident in the tracings. So this is an important slide that is showing the mean arterial pressure. How we have to measure this mean arterial pressure? See, this is the aortic pressure graph, and the mean arterial pressure is equals to the diastolic pressure, that is 80, plus 1/3 of the pulse pressure. Remember, the pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. So we have to subtract it and then add 1/3 into the diastolic pressure. So here the pulse pressure, that is coming around 90. So this is a combined picture. That is again showing different pressures, because all the chambers, they work together and they work in a collaborative approach. So these are the pressures we have to identify and remember them throughout the discussion. These are the two important phenomena which we observe during our cases, especially in the coronary cases. This is a pressure tracing that is showing the pressure waves that are taken from the radial artery. And the other pressure tracing is showing the pressures from the catheter tip. Here you can see both are matching equally. But at this point, there is something happened, and there is a pattern of the pressures like ventricle. So that is called ventricularization. Whenever a catheter pushes the aortic valve or touches the aortic valve, we usually get these pressures, and it is dangerous because it have a potential of causing acute AR, and our patient can collapse on the table. So we should avoid these pressures, and this is the another pressure. When the operator decides that he have to adjust the catheter, he did a maneuver and the pressures damped. Our panelists, they shout that the pressures are damping. So why they are damping? Because the catheter is hitting at the wall of the coronary. So again, the catheter's pressures are damping, but the arterial pressures are not damping. This also happens whenever there is a coronary with a smaller diameter. So we should see where is the problem, in the catheter engagement or in the diameter of the coronary. So for measuring the pressures in the right heart cath, we have different catheters, and the safer catheter which we usually use in our practice, they are the Berman catheters. Berman catheter have a beauty that it has a floating balloon. It has a balloon at the tip, and it flows with the flow of the blood. Whenever we go from the femoral or from the jugular, it flows with the blood and it goes into the RA, RV and pulmonary artery. It have two types. Number one type is Berman wedge. Berman wedge has a importance that it has a central hole that is at the tip. So it can avoid the pressures from the proximal part. By it, we can only measure the pressures that are distal to the balloon. Another type is the Berman angio, that is used for doing angiograms on the left, on the right side. And it has different ports and different holes that are on the sideways. So it is safer to give injections in the RV or in the pulmonary artery by using this catheter. So this slide is also important because we have to measure the pressures and they should be reliable. And for reliable pressure measuring, we have to we have to do settings in the probes, the pressure probes here, and after doing it, we have to make sure that it is at the same level of the heart. Because if these pressures are not at the same level of the heart, we will not exactly diagnose the pressures. Another important factor, before going into the DAP, we have to make sure that all pressures in the scale, in the monitor, they should be 0. So there is another slide that is also giving you a thoughtful thought that these are the pressures from where they were recorded. They were recorded from a ventricle. Which ventricle, we don't know. Why we don't know? Because we don't know the position of the catheter. We don't know the pressure scales here. So it is very much important to know what are the pressures scale, where is the catheter, because after seeing these in the complete picture, we are seeing that the pressures are 105. Can it be of RV or can it be of LV? It can be both. So what we should know, we should know where is the catheter, is it inside LV or is it inside RV? Another beautiful diagram. From heart we will be moving towards the pulmonary vasculature as well, and we will discuss a case of a pulmonary hypertension patient, and we will discuss with it the right heart cath. We had a 50-year-old female with a shortness of breath from one ear that was progressed to NYHA class 3. Her echo showed PA pressures of 75, RV and RA were dilated. We have done CTPA, rheumatologic workup, all were negative. So considering the group 1 pulmonary hypertension, we did her right heart cath. So what are the indications for the right heart cath? In ESC guidelines, they are showing that it should be done for the confirmation of the diagnosis of PH and to support the decisions regarding the treatment. Another important thing here is that the vasoreactivity testing is also recommended in the right heart cath. But when it should not be done, vasoreactivity testing, it should not be done for identifying the candidates for calcium channel blockers therapy when they are belonging to the group 2, 3, 4, and 5. So it is recommended in group 1 patients. So for right heart cath, we have different access. We have different options for access. The preferred option was femoral artery and femoral vein. Other options can be cubital, can be jugular. These are the normal pressures of different chambers. You can see the pressures on the right sides are usually lower and the pressures on the left side are definitely higher. Same as with the saturations. We have to see them that they should be lower on the right side and higher on the left side. So where we should record the pressures, we should record the pressures and saturations in different chambers. Going here, our catheter is in the SVC. And we recorded the SVC saturation there by ABGs, and that was 60%. Similarly, we have to take the saturation from the IVC. There, our catheter is in the RA, and the monitor is showing the RA pressures. We have to correlate it with the ECG for recognizing the A and V waves. Going into the depth, we have to take the saturations and pressures in RA in the upper part, middle part, and in the lower part to differentiate between different types of ASD. Now, these are the pressures that were taken from the LV, from the RV, and you can see that I was also confused that they were from RV or LV. Why? Because the pressures were 105. Echoes was showing the pressures of 75. Inside cath lab, inside RV, the pressures are 105. So that is why it is very important for the confirmation of diagnosis that the pressures may vary. So beside diagnosing the peak pressures, it is very much important to see the EDP pressures, the end diastolic pressure, because that is very much important. So after the peak pressure, we have to shift the scale and we have to see the end diastolic pressure by decreasing the pressure scale. So after that, we have to see the pressures from the pulmonary artery, main pulmonary artery, right and left in all segments. The saturations were noticed in that patient that was 60%. Now, another thing, we have to see the pressures from the LA. How to go in the LA? We have different options. Number one, directly go into the LA by a transeptal puncture. That is not an easy option. That is not a safer option. If there is ASD, it will make our life easier. We can go with ASD into the LA and take the pressures. Other option can be that we can go into the pulmonary artery, deep branches, and wage the pressures, so we will get the pulmonary capillary wedge pressures. If it is not, then the last resort, that is not a much recommended resort, but if the patient don't have MS, then we can indirectly take the pressures from the LV end diastolic pressure. That will be equals to LA pressure. So here the pressures were taken from the wedge catheter and they were recorded like this. So this is a technique of going into the wedge. They're going into the deep branches, and then before inflating this balloon, the pressures were like this in the pulmonary artery. And when they inflated the balloon, the pressure tracing dropped, and they're showing the pressures from the LA. Now, the left ventricle, again, it is important to see the pressures peak and the end diastolic pressure. Surprising that the saturation was there. That was 89%. Why? Because the patient was desaturating on room air before the cath as well. So next thing in the aorta. In aorta, we have to see the pressures from different sides, from the ascending aorta, from the descending aorta, and just from the femoral artery. And with ECG, we have to correlate because in ascending aorta, the pressure graph will be at different timing than in the femoral artery. Now, the most important part that comes after it is the calculation. How to do calculations for the right heart cath? We have to check, our ultimate goal is to check the pulmonary vascular resistance. But before that, we have to calculate different things. Number one, what is the oxygen carrying capacity of the blood? It will vary from patient to patient. A patient with a hemoglobin of 16 have a different capacity, and of 8 hemoglobin, he have a different capacity. So what we have to do, we have to have a formula. We should know the hemoglobin of the patient, and we will multiply it with 10 and then 1.36. 1.36 is the oxygen carrying capacity of 1 gram of the hemoglobin. It is in the milliliters, so to convert it into the deciliter, we will multiply it by 10. Another thing which we have to calculate for every chamber, that is the oxygen content. And oxygen content will be equals to the oxygen capacity multiplied by oxygen saturations. To convert oxygen saturations into the number, we will divide it with the 100. So it will be simple, just dividing the percentage of the oxygen saturation with 100. Suppose it is 90%, so we will divide it by 100, it will be 0.9, and we will multiply it with the oxygen capacity. These are the readings of different chambers that were calculated, and oxygen content was calculated here. So for every chamber, we have to calculate it separately. Then comes an important thing, that is, what is the pulmonary flow? Pulmonary flow is a flow that is going from the right ventricle to the pulmonary arteries, and for measuring it, we will have this equation. We will have to calculate it by dividing 180, it is a constant for adults, and by dividing the oxygen content across the pulmonary bed. What is the pulmonary bed? It is from the LA, or the pulmonary venous oxygen content, and the pulmonary artery. We will minus from the pulmonary artery to the pulmonary vein to pulmonary artery to calculate this pulmonary blood flow. So here it was 2.2. Then comes an important thing which we have to measure, and for which we did all these maneuvers. That was the pulmonary vascular resistance. So for that we will need mean pulmonary artery pressures, and we will minus them with the mean LA pressures. So here is the importance of LA pressures, and then we will divide it with the pulmonary blood flow. Its units are in volts, and the resistance of our patient was 26.27. And what is the normal? The current guideline is showing that it should be less than 2. So calculating the systemic blood flow, it is also important. We have to divide it in a similar pattern with 180. About what we have to divide? We have to divide with the saturation, oxygen content difference in the systemic circulation bed. So we have to have a saturations of descending aorta, and we will minus it with mixed oxygen content. It was 30, here it is 3. So systemic vascular resistance was, it was 3. The systemic vascular resistance was is calculated by dividing the mean aorta pressures. We will minus it with the mean RA pressure, and then we will divide it with the systemic flow. Here's an issue, it is QS. So we will divide it with the QS. Again, the units are volts, and this is, in this patient, it was 22. That was high. So how to calculate the shunt? If there is a shunt between LA and RA, in our patient there was no shunt. If there is a shunt, then we have to see that whether the flow here in the left system and in the right system, they are same or not. So the normal is 1. We will do what? We will divide QP with QS. You know the equations of the QP, you will put it there. It is a simplified equation, and by putting it, we will calculate the QP QS. If it is less than 1.5 and there is a shunt, so it will be labeled as a small left to right shunt. But if it is more than 2, then it will be labeled as a large shunt. So another important thing is that when we have to check for the reversibility, these are from the ESC guidelines, and they are showing that you have to do reversibility testing in patients with group 1. And how we will check it? We will check it if there is a drop in pressures from more than 10 millimeters of mercury from the baseline to less than 40 millimeters of mercury, with an increase in unchanged cardiac output. So we will do the reversibility testing, and this is the parameter that will decide about it. For reversibility testing, which are the agents that are indicated? They are the nitric oxide, alloprost, aproprostanol, but unfortunately they are not available here. So what we are doing it with the oxygen. So moving forward, the cardiac output. The cardiac output is another important thing that we should measure, and by measuring it, we need special maneuvers. We should know the formula for the cardiac output. It is equals to the heart rate multiplied by stroke volume. So this is very important in our future calculations. Now, moving forward, this is a right heart cath, and it will be a question for you, but you have to answer it in the end. We have to screen the saturations in different areas. From SVC, it is normal. From IVC, it is normal. It is coming into the RV, they are 85%.